We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
A very good morning, good afternoon, and good evening to all our Pioneer Fan Club members joining us on this webinar today. More so in the developed world, an aging population is a challenge policymakers and healthcare providers are struggling to keep pace with. Osteoporosis and its sequelae in the spine is our topic for discussion today, and we are grateful to have three renowned panel of speakers to share the most recent practice trends in this space. Moderating our webinar today is Professor Rajasekaran, who's the chairman of Orthopaedic and Spine Surgery from Ganga Hospital in Coimbatore, India. He's also past president of SICOT, the current president of the Asia Pacific Society of Spine, and holds various other academic accolades and is a mentor to numerous orthopedic trainees worldwide. Alongside him, we have our trauma lead and chair of the trauma committee of SICOT, Roman Pfeifer, who is a trauma surgeon, University Hospital Zurich. And together, they will be moderating today's webinar. As always, please continue to join us live in this webinar, posting your comments as well as questions as we go along. All webinars hosted on Pioneer will, of course, be available on demand viewing and our website in future. And on that note, once again, welcome to all our Pioneer webinar followers. I'm THEVENDRAN, orthopedic consultant from Singapore, and I welcome you to this webinar. Over to you, Roman.
Good morning, good afternoon, good evening, colleagues from SICOT. And I would like to welcome everybody. And I think we directly going to start with our webinar. Our first speaker is Professor Rajasekaran from India. And he is going to introduce and describe the indications for vertebroplasty, kyphoplasties in osteoporotic spinal fractures. What is the evidence? Professor, thank you very much.
Thank you very much, Roman, and thank you, Gau, for pioneering this great effort. I think SICOT Pioneer has become a great learning tool across the world, and people from all over. I'm not sure why my screen sharing is not coming. Let me do it again. Yeah. Oops. Are you seeing?
We can see your slide share version, but not now it's okay. Perfect. Thank you.
All right. Sorry. Yeah. So to kick off this seminar, which I think is very, very important, as people around the world are living longer, and osteoporosis is one of the major challenges for everybody. Now, if you look at any of these statistics, it's very obvious that more than 700,000 vertebral osteoporotic fractures occur annually. And 30% lead to painful pseudoarthrosis, immobility, and neurological deficit. Now, many studies have actually shown that there is worse physical and mental quality of life, and the residual effects of these fractures can last up to 7 years post-fracture, with a lot of disabling pain at 1 year. And what's more, there is a 5-fold increased risk for further vertebral fractures when you have one. Not just the morbidity, but actually the mortality is also increased. So all these actually makes you feel that when the vertebroplasty came, it was looked at as a panacea. Because you had an elderly patient who was suffering, whose general quality of life was coming down with increased morbidity and mortality due to immobility. And then just there was this small procedure where you could do it even without a general anesthesia. In many hospitals as an outpatient procedure, daycare procedure. And then here this patient was completely relieved of pain and walking. And that looked like just one of the things that you really wanted. And all the reports from 1980s to 2000s were all unanimous in hailing it as one of the very good procedures. And vertebroplasty was quoted to give excellent results from 63 to almost 100% of the patients. Now, as usual, enthusiasm leads to overuse, and people expanded their indications, and people went overboard. I mean, there were multiple levels of vertebroplasty which was done. Some people even went on to do prophylactic vertebroplasty. A lot of other complications associated with this. And the complications associated with this procedure of cement leakage, neurological deficit, infection, pulmonary embolus, etc. And that actually led to a lot of other things like the cement leakage outside the bone, posterior into the canal, neurological deficit. And kyphoplasty came as the second cousin brother for this, with all the advantages of it, that you need not inject the cement under pressure. You could actually create a space with a balloon, and then that all gave rise to much better results. Now, it all looked like it was safer, it restored the vertebral height, and it reduced the kyphotic deformity. And throughout the world, there was a lot of evidence generated on the pros and cons and the relative benefits of vertebroplasty and kyphoplasty. Now you could look at kyphoplasty was quoted to be better in height restoration, cement leak was much less. There was a marginal increase in the percentage who had good pain relief, but of course it was many times more expensive, and most of them required a GA, and there was a need for subsequent augmentation. So the complications were relatively less. The major complications for both put together was not more than 5%. And so there was a general big enthusiasm towards these procedures. But all this good luck honeymooning was there till 2009, when the New England Journal of Medicine actually published 2 RCTs, one, two both together, that actually said that there was no difference, no beneficial effect of vertebroplasty as compared with the sham procedure in patients with painful osteoporotic vertebral fractures at 1 week or at 1, 3, or 6 months after treatment. And that actually turned the whole thing around. And they showed clear evidence that whatever benefit was there was usually restricted to a very short period, and sometimes not all the time. But after a period of few months, there was absolutely no difference between a sham procedure and the vertebroplasty or kyphoplasty. Now, subsequent to that controversy led to 15 randomized control trials, which were all published after this controversy. 11 supported the performance of vertebroplasty and kyphoplasty, and 5 were refuting. And there was no clear consensus between the differences between which one is better, vertebroplasty or kyphoplasty. Now, I'm not going into the details of each of these, but this is the summary of all this. So why are there confusing results with vertebroplasty? Why do some reports say that they are so good and some saying that they are not so bad? Now, if you go into these, you can also find that the confusion is not only because of equal good results, but also there are many bad results with vertebroplasty. And that actually confuses the whole horizon of discussion over here. The main issue is that when you talk of all these randomized trials, most of them have not differentiated or looked into the fact that not all vertebral OVFs are the same. Now, if you look at the German Society for Orthopedics and Trauma classification, you can see a lot of different varieties. Some of these don't require a vertebroplasty. Some of these OF3 will do well with vertebroplasty. If you have a complete comminution, then vertebroplasties will not do good. And if you have a kyphosis or instability associated with it, then again, it is not going to give a good result. So you can't dump all of them together and look at what is good. For example, if you have this, a pseudoarthrosis, well established, more than 8 to 12 weeks after the fracture, and then there is a good gap, posterior wall is intact, no instability associated with it, you do a vertebroplasty, and this patient has a very, very good result. But if you have another patient which is completely opposite, there is a complete compression, everything is completely crushed, you can see that all the walls are completely shattered, there is a posterior wall comminution, there is a protrusion into the canal, there is some amount of instability. This patient is not similar to the previous patients, and when you do a vertebroplasty in these people, you can see that after a few months, these vertebroplasties go walking all around the place and you have a poor result. Another example over here, a poor indication of a vertebroplasty done in a patient with instability and a kyphosis without correction of these, and then you can see that it has gone for a bad result. And probably that is the reason that Abhay Nane Patil et al. Came out with this, that they said, you cannot consider all of them in the same plate. You have to consider the duration, the pseudoarthrosis, posterior wall status, neurology, and instability. And they have given an algorithm which is very good. Now, if you follow this algorithm and make sure that you do the right print in a patient where if you take that the duration is not a fresh fracture, that they have passed through at least 6 to 12 weeks of conservative therapy. There is some pseudoarthrosis which is formed, posterior wall is intact, no major neurology, and there is no instability. These patients have excellent results. And these I would take as the real indications of vertebroplasty or kyphoplasty in my practice. A good example is this patient. You can see 3 months down the line, a clear pseudoarthrosis formed, no instability over here. You can see that a vertebroplasty has been performed, and this patient had an excellent result over here. Another good example, pseudoarthrosis formed, no major instability, and good results with this. You can give any number of good results with the same indications. A good pseudoarthrosis, no instability, posterior wall intact, and these are the patients whom we think is very good. So you can see these good results, and in these patients, it also matters how much of cement that you can do. Now, 16% to 30% of the volume of the vertebral body, if you are able to fill with cement, that is good enough to restore the vertebral strength and stiffness, and it gives a good result, and this is very important. Now, if you do with these indications, there are enough and more reviews and articles which show that the results are very good. All of them are united to say that there is earlier hospital discharge, lower readmission rates, reduced mortality, and there is growing evidence that people who are treated for 6 weeks and more after fracture onset, they give a better result. Nothing much to choose between kyphoplasty and vertebroplasty, because kyphoplasty is superior in all radiological outcomes, but not so much different in clinical outcomes, except that kyphoplasty is much more complicated and much more complicated, needs sometimes a GA, and also is many times more costlier over here. The refracture rate is almost the same. It doesn't matter whether it is vertebroplasty or kyphoplasty, and it more depends upon the age, the bone mineral density, your Kobbe ratio, your VAS score, and the bone cement leakage over here. If you are able to use a high viscosity cement, it's much better. Your leakage rates are even lower than the kyphoplasty, and it doesn't really matter whether you are using a single portal or a double pad. Now, what is very important to know if you're practicing is that the contraindications for a standalone vertebroplasty or kyphoplasty. Now, these are what we find in our practice. Now, this patient has got a complete reduction of the vertebral height. There is a kyphosis and a posterior disruption. You can see that there is a wall, the anterior wall and the lateral wall and the posterolateral walls are all disrupted. There is a fracture on the posterior column 2, and then there is an extrusion of the wall into the canal. These patients traditionally do very badly with a standalone vertebroplasty or kyphoplasty, and they require an augmentation with fixation. Now, this is very important. In any one of these indications where these factors are there, if you operate with standalone, you get a poor result. Another good example, a complete collapse. You can see that there is a splaying. Whenever you find a splaying of the vertebral body, and there are multiple defects on the extending up to the posterolateral side, and an extrusion of the body into the canal, these patients should not have a column. Another example, you can see a complete splaying, and this is very important that you should always augment these fractures with this. Another one of the examples that we always have found, an important point we have learned, that in patients who have a big gap, but in whom the first 2 or 3 levels above are also fused by bridging osteophytes. Now they have a stiff spine equivalent of a stiff spine. You can find here there are bridging osteophytes extending to many levels. And also on the posterior side, you can find that there is a lot of facetal stiffness. These patients again do badly with just only a vertebroplasty or kyphoplasty, and it is better that they undergo fusion, augmented fusion. So I think it is very important that we look at the typical symptoms of compression fracture, and we also have a radiological evidence of fracture which is non-healing, and then we differentiate between the common low back pain and coming from the OVF. And if you are able to get a clear pseudoarthrosis, and then you can have the alligator sign positive, opening up on the extension views, and if you can find that there is a difference in flexion and extension, and if you do a good workup where you will rule out myeloma, metabolic bone disease, and do a complete workup to rule out metastasis, and then you do a vertebroplasty or a kyphoplasty, there is nothing much to choose between these two, the results are excellent. The poor results of vertebroplasty are actually not due to the cement, but due to poor indications or a wrong performance. Thank you very much for the opportunity, and thank you.
Thank you very much, Professor Rajasekaran, for this presentation. And we're moving to the next presentation. As this is it's my presentation. Just let me start. So can you see it? Is it visible?
Yes, Roman, we can see it.
Thanks. So welcome everybody, and thank you for joining this webinar. And I would like to speak today about management of osteoporotic spinal fractures. We have heard in the last presentation the indications for vertebroplasty, kyphoplasty. And I would like just to sum up and to add just a few clinical cases from our department. And probably there are some differences in management, so in the end we can discuss about it. And also I would like to show some new devices, new techniques, which are present at the moment in the industry. There will be some choices in the future to improve these techniques, but it's also probably a matter of time, and will show us whether it's useful in the future or not. So I would like to show you one case from our department. This is a 77-years-old female patient. She has already known osteoporosis and platelet function problems. And she had a fall from a standing position at home, and she had an immediate back pain. So we saw this lady in our emergency department, and we saw this as a minor fracture, I would say, osteoporotic fracture of L1. But usually, if she has a pain, we take the patient to our ward and try to mobilize the patient with a pain treatment. And we saw that during the clinical course, there was an increase of pain of the patient, and you see this compression of the vertebral body after a couple of days after mobilization. And that's why we decided to do an operation. This lady's indication was, of course, the persistent osteoporosis, increase of the pain and the collapse of the vertebral body that we saw before. Usually our techniques in such patient is so-called spine jack. Probably you have heard about it. So it's a spine jack, and this is a jack what you use for example, to repair your car, and the function is similar. And what we do here is, for example, it's an operation X-rays from the same patient, from the same lady. After positioning the spine jack here, you allow the restoration of the vertebral height, shown here on the left side. And after injection of the cement, you can fix the position of the bone and avoid further compression of the vertebral body, like it's shown here. And so this lady had a pain reduction, and so was able to ambulate in the next days. And so discharge was even possible here after 24 hours. Of course, it doesn't work not in every patient. I will show you later a few clinical cases where it was not so easy, like it's here in this patient. So that was a follow-up after 6 weeks. So there were no further changes in the position of this fracture, and even after 12 weeks, the quality of this picture is not so good, but it's only one what I have at that time, and there's also was no change. And the patient was after 12 weeks good mobile, but still had still persistent pain, but on a lower level. If you speak about spinal and the spine jacks, there's 3 different types of spine jacks. You have a small one with 4.2 millimeters, which I usually use on the thoracal spine. Then you have 5.0 millimeters, where usually we use it in thoracal lumbar spine, and then we have 5.8 millimeters spine jack, where they usually use in the lumbar spine. So it's similar like other percutaneous techniques, kyphoplasties. If you're inside of the vertebral body in a fractured area, you try to position your spine jack close to the fracture and in the area of the fracture, and after expanding, you can reduce the fracture to, and if it's possible, but not possible in every situation, we can reduce the anatomy. And then after that, after injection of the cement, you can probably fix the position of this vertebral body and avoid further dislocations or further compressions. This is there are only a few biomechanical studies existing about the spine jack, and you see here the positioning, the right positioning of this spine jack. Here you see it very close to this osteoporotic fracture. In this, after having this in this area below the fracture, you can increase here the vertebral height and somehow restore the anatomy of the patient and avoid further dislocation. So this was one case. The second case is, of course, similar, but it goes in the same direction. 79-year female patient. So she was a delay of admission, like 4 weeks. Patient was initially treated by the family practitioner, and she had already known osteoporosis and degenerative problems in all joints. She had also a fall from a standing position and also direct back pain. You see here, and this lady had also not only a fracture of the vertebral body, but also posterior articular parts had a fracture, so that we diagnosed here type B fracture. And in this patients, we also try to do a spine check to restore the anatomy, but at the same time perform here and a percutaneous dorsal instrumentation with augmented cemented placement of the screws here in the vertebral body. You see the bone quality is not so good. And there was a situation after the operation, and so the pain was reduced here, the same patient as well. And so ambulation in this patient took a while, and this lady could go home after 4 days after surgery. So in the third case, also probably like reported before, you assume there are also some complication or problems with this implant that can happen, and I try to show you with the case number 3 what can happen and what kind of problems this patient can also have if he uses implant. There's another lady, 74 years of age, and so we admission circa 1 week after trauma. She has also an osteoporosis, like our patient before, and she had a sudden pain, not a direct trauma, after mobilization from bed. So, and she went directly to the family doctor, and he did an MRI without an X-ray. And on the left side, you see there's an old compression fracture of L1, and you see this edema, and it was present here in L2. So this was the reason for back pain of this lady. We classified it as OF2 fracture. And this was the X-ray after the mobilization of the lady. You see, this is an initial fracture, probably old, and this is a fresh fracture confirmed by the MRI. So we tried to mobilize this lady, and after 4 days of severe pain, and we decided to perform again here and treatment with a spine jack, and to reduce, with the aim to reduce the pain of the lady. And like you see it here, again, this is a positioning below the fracture area. We try to expand as far as possible, and we are always afraid to break through the vertebral body and go into the vertebral disc, and then we inject the cement to fix the fracture here in this position. But you can see here the neighboring vertebral body has still a high here, and this was confirmed by a previous MRI that it was not really fractured. But if you observe, here's a post-operative follow-up of the patient. It was 3 months, 12 months. You see that the compression here of this fracture of adjacent vertebral body increased over the time. This lady, interestingly, had not so much pain during the clinical course, but still we observed these changes here. And of course, it's very often associated with a cemented bone here, which has effect here in the compression, has effect on the adjacent vertebral bodies, and leading to here associated fractures. What are another problems of this implant? It, of course, similar is a leakage of the implant here to the posterior side. This lady had no complication, but still, if you have such situation, be careful. And in some situation, you need to perform laminectomy if it's required. Then you can have here dislocation of the implant of the spine jack into the vertebral body, like it's shown here. And of course, it's the restoration of the numerical restoration of the vertebral body was not possible. I could see it here. And in some situation, even if you have a sclerosis of the bone due to another bone diseases, you see at some situation you have even rotations of the implant, like it's shown here. course, and then it's the aim, the restoration of the vertebral height is also not achieved in this patient, and so this is a complication we have observed. A few studies exist with a focus on the restoration of the vertebral height. He is published from some colleagues, and you see here there's in this biomechanical study an artificial, I would say, an artificial compression time fraction was induced, and restoration with the spine jack or kyphoplasty, balloon kyphoplasty was analyzed. And then usually in an anterior part of the vertebral body can restore, and using these techniques, it was much better possible than if you use a vertebral standardized balloon kyphoplasty like shown here. And a few clinical studies also exist with the topic of spine jack. You see only 222 osteoporotic fractures with and 81 patients with non-osteoporotic fractures. It's only in minor group, but using this technique, you can reduce the pain treatment, the pain in the patient in 48 hours, 3 months, 12 months, and also the mobilization of the patient using the OGS score. So just to probably to conclude in that and show what other techniques exist, to show you other options that probably there are some companies show lowers have implants to use vertebroplasties only from one side and spread the cement also because the contralateral side, so it's less invasive than techniques before. Also the positioning of the balloons are possible to do it from the unilateral side, like it's shown here. You have two different balloons if you want it. So it's double balloon techniques. For example, if you have a compression type fractures, you can blow up anterior part, anterior balloon to restore if you want it, and then you can use the posterior part which you can blow up, and then you can have a restoration of the vertebral body and then use a cement after it. So there are different techniques that and devices that exist now in the industry, and also such tripod techniques where you just put in every area what you would like to expand and fill with a vertebral body. So in conclusion, so there's of course an osteoporotic patient and patient with this patient, usual geriatric patient, have less reserves. We need to focus on percutaneous cemented augmented techniques. There are several techniques that are present, but there are no real literature exists that proves the function of these techniques, and there's no long evidence, no long-term studies that evidence the function of these devices. And probably the future will show us what else we can do to improve the quality and life quality and this patient, and also to improve the outcome. So I would like to thank you, and I would like to give next to introduce Professor Kobbe. He is from University of Aachen in Germany. He's an expert in spine surgery and spinal trauma. And Philipp, I would like to thank you that you're here with us and show your experience and your results. And I'm really happy to hear your presentation. Thank you very much.
Yeah, Roman, thank you very much for the introduction. And both of you, I think you showed already some great cases. And we already heard in the first talk that it's not the cement that doesn't work. It's really about the indication. And I think in your third case, Roman, you showed well why in some patients it may not work. And I want to show you now in my talk, let me just share with you why it sometimes doesn't work. And it's really difficult because the evidence is pretty much low, and you have to really look in each study to get an idea really why some cases may fail. Can you see my screen, Roman?
Yes, I can see it. For the weekend.
Perfect. And So, yeah, what is the evidence? And I mean, this is not new for you, but if you look in the internet, you see that you have so many hits with osteoporotic vertebral fractures and what treatment you may choose. You have a lot of hits for conservative treatment, a lot of hits for kyphoplasty, but not as much as you have for not as many for posterior stabilization, which will be my topic mainly. And the problem I see is, if you look in the studies, you have a total different bunch of osteoporotic spinal fractures. But what we mostly do, we just put them in the box of osteoporotic vertebral compression fractures, mix it in this black box, and then there are studies which look whether, conservative treatment worked, they looked whether kyphoplasty may have worked, and they looked whether kind of posterior hybrid stabilization worked. But the main problem is that there's no study focusing at each individual fracture pathology. And we already saw in the first talk that there's actually a nice classification from the German section, and Klaus Schnarke mainly did the effort to publish this. And I want to choose this classification to go through you with each of those type of fractures and explain which indication may work, and explain what kind of at least radiological factors may give you a hint that kyphoplasty or even conservative treatment may actually fail. And if you go for OF1, I mean, this is nothing new for you. I mean, conservative treatment is, of course, treatment of choice. You mainly probably don't even find it, because if you don't have an MRI, you won't really see it in the CT scan. However, you have to be aware that if you look in some studies, there's still a predictive factor for therapy failure for conservative treatment if you have a large vertebral edema in the steer sequence in those patients. And I then think even in those OF1 fractures, kyphoplasty may even be an option. Of course, posterior stabilization has no indication. But if you look in this case, you can't really see the fracture in the CT scan, but we did an MRI because this man had a lot of pain, and you see that you have your fracture here, you have some edema, and even with this really mild fracture, you see that after 3 months, you have some sort of deformity in this vertebra. And this is something I want to mention probably right now. We have to be aware that most of the studies look as outcome measure for pain. And I agree that in most patients, the kyphoplasty works. But most of the studies don't look at height restoration or look at sagittal alignment. Roman, you just showed a study with height restoration, but there's just a new meta-analysis which shows that it's not really possible with cement augmentation to hold the sagittal alignment we want. If we look now at OF2 fractures, and those are actually only have like a mild deformity, they have no or just minor posterior wall involvement. There actually, if you look more in detail in the studies, conservative treatment is already critical. You have a lot of predictive factors for failure. If it's in the thoracolumbar junction, for example, if you have posterior wall involvement, and we already saw this in the first talk, there are also some MRI signs which are really important. For example, if you have this cleft sign, the intervertebral vacuum phenomena, if you see this, or if you have this swelled front type, which is a kind of indication that you have the anterior ligament injured with this bony aspect you can see in the CT. And then you also have the so-called linear black signal in steer, which is also an indication that conservative treatment may not work already in our type 2 fractures. And then, of course, kyphoplasty is more often indicated than most of us probably will have thought. But then we come to a very important aspect when kyphoplasty, and those cases, I mean, the third case of you, Roman, which you showed, shows this. If you have a larger end plate defect, if you have a larger end plate defect, more than 3 millimeters, I mean, we can argue whether, how you can really show that or measure this. But we have to agree that if you have an end plate defect, kyphoplasty has a higher rate of failure, which increases by an odds ratio of approximately 7 to 10. And then you have to think about the posterior stabilization. And I want to show you here this case, for example. I mean, this is this kind of front swell type with conservative treatment, and you see what's going to happen. You will have a flat vertebra. Also, it doesn't really look that bad in the CT scan initially. And another example is, for example, here for this 71-year-old lady with this L1 fracture, and you see in the MRI, you see this large edema, you see the swelled front type, you see this cleft sign. And if you do, for example, just kyphoplasty, which I did, and I agree it's probably working for the pain, but if you look at these patients with end plate defects also, which you can see in the MRI, after 12 months, they're still pretty okay with the pain, but you can see they have a loss of reduction. They have a sagittal malalignment already in this segment. And this is something you cannot really achieve with kyphoplasty. You cannot really hold the sagittal alignment once you have reduction in VOR. And now we come probably to the most difficult part. It's the OF type T3 fracture. It's kind of the incomplete burst fracture of the young patient. And it's you have only moderate deformity actually, and only still minor posterior wall involvement. And I think we can agree that conservative therapy is not advisable in these patients. But another aspect is we have to look at is height loss and kyphosis. And then you should definitely think that you may need an operation. But also with kyphoplasty, it's a really critical indication for those type of fractures, because you have, by definition, an end plate defect in those fractures. And often, and Roman, I think you also showed a case, and we saw a case in the first talk, you usually have a segmental instability. And it's very easy. You don't need flexion extension views. You actually can just use your CT scan or MRI scan and then get a standing X-ray in the course, and you will see if you have a segmental instability around 14, 15 degrees, you will have a really, really high risk of failure if you do a kyphoplasty in these patients. And therefore, already in OF type 3 fractures, kyphoplasty may not be an option, and you should have to go for posterior stabilization. And I show some cases here. This is, for example, this is a classical case. You see this L1 fracture. You see it here in the standing X-ray, and here you see it in the CT scan. And if you compare it, you already know that you have a segmental instability in this lady here. And you also can have your MRI scan. You see this end plate defects you have in this area. You see you have a large amount of edema in the vertebra. And if you do kyphoplasty, and this is from our clinic, this doesn't work. It will definitely fail. And you see after 1 month, and this is exactly what Roman, I think you showed in your third case, you will have cement creeping over time in the disc space, and you will have probably then even adjacent fractures if it goes really bad. But at least you see you have a segmental malalignment in this patient, because the kyphoplasty is not the method of choice you should choose if you have those predictive factors for failure. And what you should do, in my personal opinion, is, for example, in this case, you see this L2 fracture in this old male patient. You see here the end plate destruction. Actually, you see the vacuum phenomena in the vertebra. And this is the best case, actually, to show you the benefit of the so-called hybrid stabilization. So where you do a short posterior instrumentation, probably you should use cement augmented screws, and then you kind of support the anterior column by augmenting the vertebra with cement. Because we know from the old people, they have usually really stiff discs, they are dehydrated, and there's not so much movement as in young patients with a disc in older patients. And in my personal hands, I think it's important to do this stepwise. So what we do is we put the patient in a prone position, and then we actually kind of do first instrumentation, and then we go very lateral in the vertebral body and do the cement augmentation. So if you look at the OF type 4 fractures, this is actually, if you compare to younger patients, would be the complete burst fracture or the pincer fracture. At least we have to see that we don't have any frame structure left. Of course, this is usually no indication for conservative treatment. And again, kyphoplasty doesn't really have a good indication in those fractures because, I mean, just by definition, we have end plate defects. Usually you have segmental instability. And another factor is that we have the loss of the frame structure. And the cement has no chance to give any support if you don't have a frame in which it can work. So again, a very hard indication in my hands for a posterior stabilization. And this is here the case. It's probably not the best case to show you what's happening if you do kyphoplasty, but you see this case here. You have a OF type 4 fracture. You have already have here some vacuum phenomena in the vertebra, but also in the disc space. And someone in our clinic had a great idea to do kyphoplasty, but you see it right away. The cement goes into the disc space, in both disc spaces, and we know from studies that it doesn't really help in terms of stability in those cases, and you even increase the risk of adjacent fractures by, I think it's 10-fold times if you get cement into the disc space. So this is not a good indication, and this is how I think we should do it, again, with a hybrid stabilization in those cases. And this is what I wanted to show you earlier. So in my hands, I first do the kind of reduction maneuver with my rod, with my pre-bent rod. Of course, I use polyaxial screws, but you can get also some slight reduction. And then I go in with my kypho needle or whatever and put in the cement, because you create already a cavity if you do your reduction maneuver with your implants. And then there are also cases where we have to admit that the hybrid thing doesn't work and where we have no chance to support our anterior column. And this is the case of an L3 fracture. And usually I don't do this, but for me, I think it's impossible to kind of augment this L3 vertebra with this type of fracture. So then I personally think if we want to have a good alignment and keep a good alignment of the anterior column, we have to be aggressive in some cases. And then we even go for vertebral section and cage implantation with those distractible cages. Very, very important is, even with larger end plates, as in this case, you will not get, you will get cage subsidence. So what you have to do is, and this it's difficult to see, but when you do in the anterior axis, I always augment the end plates here with cement additionally, so that your large cage has a very good and nice end plate structure and doesn't have any cage subsidence in the cross. And the last is the OF5, and I was actually surprised by one of your cases, Roman, where I saw some posterior involvement. I think it was the second case. For me, this would have, by definition, be rather OF5, where you have some distraction injury. And this, I think, there is no room for any just anterior support, as we know it from young people. So this is something you definitely have to solve by posterior instrumentation. And this is the case with this T7 fracture. And you see with the arrow here, actually, this fracture of the spinous process. And this, for me, is enough. I don't even need an MRI because I don't want to take the risk to do this with a posterior augmentation. So in summary, I mean, this is just, I think it's pretty aggressive, but I just want to show you that there, also for kyphoplasty, there are a lot of factors which you should look at because they may indicate that just kyphoplasty may not work. And if you do this and go after this classification, the OF classification, there's actually not so much room in the higher grades of the OF classification for just kyphoplasty. And so I hope that I could at least give you some hints which may indicate therapy failure. And I want to close actually with this last case because I think it's just just shows that some people overstress the use. And you see here, it's just a part of the spine. But what you see here, that this lady here has this L2 fracture. Probably we would classify it as OF3. And what the colleagues did, actually, they did a kyphoplasty. I mean, it pretty much looks, I think, not that great, but it gets even worse if you actually look at the whole spine before. This was the spine at the accident, and you see this severe kyphosis at these old levels of kyphovertebroplasty. And I mean, I think this is not what you should do. So you always have to look at the patient. You also should look at the whole spine, and then you should decide what's the best individual treatment for this patient. And I think we all would agree that just a kyphoplasty in this patient is probably not the best choice. If this is the best choice, I'm not sure either, but at least you have a realigned sagittal alignment. Thank you very much.
Philipp, thank you very much for this interesting presentation. So we have one question from the audience, and he is the one colleague who's asking, what is the post-surgical intervention protocol in your hospital in patients with vertebroplasties or kyphoplasties?
In our hospital?
Yeah, in your hospital, for example.
Full mobilization after surgery. We don't use any casts. Usually, we don't use casts. So I know there are some hospitals who use casts, but we don't use any casts.
Mm-hmm. But you just mobilize the patient, try to be active, or is there any strategies?
So no, I personally see, we all know these patients, okay? They're usually not really mobile. So once we decided to do surgery, the only goal is to get them out of the bed as early as possible. And so, we try to get them out of the bed the first day.
Professor Rajasekaran, do you do something different in the rehabilitation of these geriatric patients?
No, I fully agree with Philipp. The central aim of this whole procedure is pain relief. And second is mobilization and getting them out of bed, and to prevent all the stay for sure. Regarding the corset or a belt, I just leave it the choice to the patient and the physiotherapist. I tell them medically it is not indicated, but if it makes you feel better, you can wear it. I leave it to the choice. And I guess in our patient population, 50% opt for a belt, they say, a corset, they say they feel comfortable, which they can have it for some time.
And I have another question. What is the role of MRI in this treatment? Is it a must in every situation, or how do you decide?
Yeah. So MRI has many values. If it's just to look at what is the etiology of the fracture itself. One of the things that you're really worried about in this patient population is whether it's a pathological fracture. And I think MRI has really a good value to make sure that it is a post-traumatic osteoporotic fracture and not having a pathological component. No metabolic element massively involved, or it is not a metastasis. It also allows you to, just like Philipp said, an MRI gives you an estimation and an assessment of the whole of the spine, which is very important. Now, many times we find in these patients, they have subacute fractures higher above. If somebody comes with L1 fracture, but I see some fractures and compression, old fractures at a higher above level 2, which is compromising the whole sagittal balance, then these patients are a complete subset where you need to be careful. If you also can see a cleft, if you can see a fluid collection, a Kummal sign there, a positive cleft sign, then it's a definite indication for vertebroplasty or kyphoplasty. So I think MRI is very useful for me. In every one of these cases, I would do an MRI.
Thank you.
Yeah,
Philip, do you
I totally agree.
Yeah.
Oh, sorry, Roman. Yeah, I totally agree. I think there's actually, I read it a few years ago, very interesting study which showed like in how many time of your cases the MRI would change your strategy, or how many, and it was like more than 70%, I think. So as we heard, I mean, I think whenever you can get the MRI, you should get it.
Then another question. So how long do you wait until you do the surgery? So if you have a patient admitted to your hospital and this patient has pain, do you directly plan the surgery or try to do it first conservative, of course, if indicated? Or do you plan directly and try to, what is the strategy here?
Yeah, I think it would differ from country to country, institution to institution. In my place, we have stopped being very aggressive in the last few years, so I do a fair trial of conservative therapy for 3 weeks. But there are certain instances where we have broken this rule. If the patient has unbearable pain, we sometimes go ahead and do it within the first few days. But generally, in more than 80 to 90% of my patients, I would just give a fair trial of 3 to 4 weeks. If the patient comes with an established non-union, or if they come 6 weeks later as the first presentation, and then I find there is no signs of union and they are having a lot of pain, then I would go straight away.
Yeah, I think, we also have pretty strict guidelines actually in Germany, but we sometimes just, don't use them. I think it's very individual decision. And there are two important things. I mean, one thing is the pain. And I think most of the patients, I agree, we could treat conservatively. But the other thing we have to think of is, I think, sagittal balance, sagittal alignment. I mean, we do so much thinking about what would be the age-adjusted balance or whatever of some patients. And then we have to see that some of those fractures, for example, OF4 fractures, I mean, from admission of the patients, they will end up in a sagittal malalignment. You have to decide on a individual base. I mean, some of those patients probably doesn't matter if they're 85 and only move at home, but some of them still play golf or whatever. So I think it's about pain and about what alignment we want the spine to be. And then I don't wait too long because it just gets more difficult to realign.
It's also, there is a social element to it, and what is their family support?
Yeah.
I mean, that's another big issue. I mean, nowadays, even in a country like India, more and more people are living alone, and it's just elderly couples living alone. And it's so much difficult for them for 4 weeks with intense pain. And so I agree with Philip that it's a case-to-case, individualized decisions have to be made.
Roman, one colleague. Yeah, sorry, yeah.
Can I ask both of you a question? So both of you were emphasizing in your talks about restoring the height. I do agree that sagittal balance is a main issue. But how important is it to restore the height to its normalcy? Because we frequently see patients who have collapsed a little, maybe to 75% of the height, not of kyphosis, but there could be a type 2 collapse. And how important is it to restore the height?
Yeah, I think this is a perfect question, actually. I think you're totally right. I think height, for me, height doesn't matter. It's more the kyphosis. I mean, usually, I mean, you have a kyphosis if you have loss of height. But yeah, if you just have a, let's say, very homogeneous fracture with loss of height, so the height for me is not of importance. It's more about the segmental alignment. And also this, I mean, we have to admit that it's there's no proof that radiological malalignment is really associated with pain. But I personally believe it is, and I personally also believe that we have, and this is proven, I think, a higher rate of adjacent fractures. So this is why I always emphasize about the alignment. But again, I mean, I think it makes a difference for all people whether they just have cement or whether they already have some kind of metal in their back. So I agree with your talk that a lot of our fractures are, from the pain side, manageable with just cement.
So in our hands, it's I would say so our hospital leaders, the spinal surgeons, mainly try to restore the height of the vertebral body. So the idea is to restore the anatomy like it's in other fractures as well. So that's why we try to restore the fracture. We also know that it's not always possible. So also there will be old, already healed fractures, and now with the new fresh components. And we try, as if it's possible, to restore the anatomy. And but we also we also know that it's not always possible, and to accept the situation. And if it's not complete restoration of anatomy is possible in this couple of patients.
Yeah, the reason why I asked was, in an osteoporotic fracture, where at least the superior end plate is completely broken, shattered. In those cases, trying to restore the height actually puts a lot of pit holes into the whole bone, and you could actually cause more complications. We have found that in these patients, it's much better not to restore the height, but actually to cause some spinal compression. You reduce the kyphosis, cause spinal shortening, and then compress. They do much well, less costly, more efficient, and it's just a philosophy of thought. We don't worry too much about height.
So very often, usually, if you put a patient on the prone position, you see that in many situations you have you put the position already in like physiological or like in normal position, and then you need just to fix it somehow, or either with this other devices or vertebroplasties or kyphoplasties. So we see it many times, and see that's why we try to restore as often as possible. I know, but in some situations it's not possible anymore. So one question here from the audience. So what is do you use adjuvant treatment for osteoporosis? So do you use bisphosphonates? How is every patient is treated for osteoporosis in your hospital, or is there another strategy?
Well, I think this is probably the most important aspect of the whole therapy. And I personally am not that good with those medications, but we always try to initiate it, because otherwise the whole surgery or whatever we do would be useless if we wouldn't start on adjuvant therapy for osteoporosis.
Thanks. So, are there any questions? Let me see to the chat. Philipp, do you have any questions, or Professor Rajasekaran?
No.
So if there are no questions, so I would like to thank everybody for participating. I think they were really, really good talks, and I learned personally a lot from this, and we had a good discussion in the end, and see each other next time, and I wish you all the best.
Thank you, Robert. Thank you, Philipp. Go, thank you. See you later. Bye-bye.
Bye-bye. So, Roman, jetzt sind wir ja wieder im anderen Modus, ne? Dein Mikro?
Ja, danke. Danke dir, dass du dir Zeit genommen hast. Ich denke, das